Well, good evening, everyone. Thank you so much for joining us today for our webinar on the future of health policy. We are so delighted not only for your presence, but we are also delighted to have our panelists. Our first panelist is Ms. Ijoma Ejekize. Then we have Dr. Jamila Mitchner and Dr. Deandra Atoyibi. And my name is Brittany D. Hazard-Bigby. I am your moderator for the evening and the national chairperson of the SNMA. So we'll go ahead and get started, jump right in. So tonight we're going to be talking about the COVID pandemic and the vaccine and how we as medical students can really think about the future of health policy as we kind of weather the storm of coronavirus together. So my first question is going to go to the panelists. Whichever one of you guys would like to answer, we'll just kind of go around and share the mic, so to speak, in our responses. So the first question is, I think the one that everybody wants to know, what does our future really look like? Is there a way for us to pandemic proof the hospitals or nursing homes? You know, it's probably likely that coronavirus will be with us for a while, but do we think we'll ever get to a place where we really don't have to worry so much about this virus and its effects on our health? We can start with Dr. Mitchner.
All right, happy to jump in here. I want to say, yes, we can get to a place and we will get to a place where everything goes back to the way it was before, to some degree of normalcy. And I think that we will certainly get closer to that than we have been for the last 10 or so months as the vaccine rolls out and more people are protected from the virus. But I also think it's important to be honest about the fact that we'll likely never quite be, things will likely never quite be the same again. And they probably shouldn't be the same again, right? Because we weren't prepared going into this. And so if we go back, if we reset to normal, to what our old normal was, then it will leave us unprepared for when the next crisis hits. And I think pandemic proofing is a very useful concept. And if you think about it in the context of like medical care, right? Direct health services and care, there are all sorts of ways we can understand, really concrete ways we might understand what pandemic proofing really means, right? In terms of what sorts of supplies and resources do medical institutions need to make sure that they have access to? And how can we sort of be ready for pandemic 2.0, whether it's COVID or something else? But I also think part of pandemic proofing is thinking about how to deal with the structural inequalities that have made us so vulnerable to COVID-19. And so what does it mean to pandemic proof so that race and class and zip code, geography, and age and a number of other markers don't become markers not just of demographics, but markers of vulnerability. And so pandemic proofing from the perspective of how to deal with structural inequalities, I think, is the real question to ask ourselves. And that has implications way beyond the realm of healthcare, but it also has implications for public health resources and for healthcare workforces more broadly, right? Ideas like, hospital utilization and trying to avoid underutilization and make sure hospital beds are maximized in terms of how they're being utilized might not seem as appealing post-pandemic when we realize a little underutilization might be good because it gives us cushion, right? For when something happens, there's kind of room in the system, there's give. So there are all sorts of ideas and notions that I think were certainly in vogue prior to this pandemic that we're going to be thinking differently about before. And then there are things that we weren't thinking enough about or investing enough in public health infrastructures, the healthcare workforce, that we're going to have to invest in much more if we want to get ourselves to a point where we're anywhere near what we might call pandemic proof.
Thank you, Dr. Mitchner. Dr. Atoyibi, did you want to add to that?
Gladly. So I don't think we will be able to pandemic proof totally in any near future. Every few generations historically has had some type of pandemic. In the early 20th century was smallpox pandemic. And then 30, 40 years ago, it was the HIV/AIDS pandemic. So it comes in different shapes and sizes, and that's the challenge. So the COVID pandemic has been different in the fact that it's so highly virulent and easily spread versus HIV/AIDS as well as prior other infections. So it's going to be hard if there was something else that comes out later on that's maybe transmitted in a different fashion. And we're now prepared for airborne and droplet precautions. But if there was another type of infection that came out similar, let's say HIV, that was passed through bodily fluids and we didn't know that, it's going to be challenging. But I do agree with Dr. Michener, and also just have to point out that other countries are succeeding at battling this a lot better than we are. So New Zealand, for example, has done great with flattening their curve. And I do think I'm a little optimistic in terms of getting back to some normalcy. It's going to be a few years. I don't anticipate 2021 finishing off without us wearing masks. So I do anticipate it's going to be a couple years. And again, as we learn more about the virus, learn more about the efficacy and how long the vaccines are effective for, they're already talking about making possible boosters to fight off the new strains. So as we continue to learn more about how the vaccine can be effective and have more studies information, I do think the vaccine will give us some hope of returning to some normalcy, as the smallpox, for example, vaccine helped to eradicate smallpox, which was causing quarantines and ravaging communities back in that timing. So looking back in medical history, I do see some hope as communities and countries have studied and overcome prior pandemics, but our public health system has shown with this situation that it is truly not up to standard, even comparing to other countries. Our response was not effective, and the discordant response between the healthcare system, the political system, the local government, state governments, it has just made this a botched approach. So I do think we could have more pandemic prevention in the future if we were on a greater front unanimously, instead of what's still going on of a lot of resistance to some of the recommendations. But I'm a little optimistic, again, looking back in medical history to see how mankind has overcome prior pandemics. And again, it may not be COVID, but there's always going to be a new virulent something that's going to be affecting our day-to-day life. So our preventions that we may implement now may not work for the next whatever the pandemic will be. But I'm optimistic, again, if we can restructure our public health system and our response, that would drastically impact our success in the future.
Thank you. So speaking of our response and how we prepare ourselves to handle another pandemic, this one or otherwise, I want to ask Ms. Ejikize, what are some things we need to be thinking about when we are trying to gauge our local and state government officials and wanting a better response? What are some things that we as lay people, not even medical students or physicians, et cetera, but just lay people need to be thinking about asking to better that response?
To go back to the first question, actually, I also wanted to add something. There's also a political dynamic that a lot of people don't take into account about the way in which our federal and state government officials, regardless of party, perceive the importance of science and public health as a not more so just legitimate cause to pay attention to in general, but just something that's critical to any city, state, or nation's future. I'm sure some people have saw the report recently, I think yesterday or a few days ago, of it being revealed that a lot of funds that have been appropriated to BARDA and a lot of other parts of our larger federal public health response apparatus have been abused They've been used for administrative things, office repairs, and other things that they were never intended to be used for when Congress appropriated them in the first place. So that's a general problem, the attitude that folks in the policy space, many of whom do not come from a science background, do not have education in health policy in general, but have a lot of authority and say in matters regarding health policy control. They really don't understand the importance of science, especially infectious disease science. That's why a lot of infectious disease research and programs in the United States are historically underfunded. Beyond that, there's also the issue of the fact that a lot of our vaccination policy, and I'll get to this later, in the United States, the jurisdiction skews toward the states. So past supporting research and development for vaccines coming to market and having some sort of advanced purchase agreement with manufacturers, getting the FDA to give an EUA or formal approval, having ACIP at the CDC provide recommendations. Beyond all of those things, the federal government's hands are tied. They can only provide recommendations through CDC, HHS guidance, but state governors have a really big part to play because they can listen to federal guidance and recommendations, or they completely can disregard them. Also, we could have a situation like we had in the previous administration where federal guidance is just really not quality or so vague it's not meaningful on the ground. Beyond all of that, just like Dr. Mitchner said earlier, we're going to have a big inequities problem, even if hospitals who really felt the brunt of this pandemic on the private side, on the private payer side, dealing with insurance companies and not being able to cover the costs of COVID-19 care or testing or vaccines. A lot of those hospitals, even if they do pandemic proof and change their built design to prevent the spread of a future virus in a future pandemic, that could skew toward richer neighborhoods, wealthier cities, and skew away from rural and underserved communities as well. But to your second question, I think medical students, especially medical students of color, are the future, literally, of medicine, and should shore that up when engaging with their members of Congress, senators, especially their state officials, because control over most infectious disease responses really does lie with the states. A lot of folks don't know that, so they'll skew toward Congress and yell at Congress when really you're yelling at us because we're staffers, and make demands that our bosses can't actually do anything about, because past signing a bill and being the kind of like coin purse of America and providing funding to the states, the use of the funding is out of our hands. So if you have certain governors, like Democratic or Republican, who refuse to use that funding properly for COVID-19 testing, vaccines, PPE, et cetera, it's literally out of our hands. There is a role to play with a new administration that we now have, but how powerful that is depends on how receptive and forthcoming state governments are about what they need and what the real issues are with testing, vaccines, et cetera, in their state. So I really think medical students are on the ground, they see what's going on, and they have an opportunity to leverage that lived experience as students and future physicians to really take their state governments to task.
So I want to stay with you right there for a second. So one of the things we're seeing as students, I'm currently on my family medicine rotation, and one of the things we've been talking about is interstate travel to get the vaccine. Obviously, we can talk about some of the barriers to vaccine distribution. I'm currently here in Florida, in Miami, Florida, and we've discussed some of the inner city travel that's happening because most of the Black and brown communities here have been looked over in Florida. and that's posing a huge problem. And so even, those who are not necessarily part of the Black and Brown community are going to other counties, et cetera, and that becomes a burden to their supply. The hospital here has run out, so those who have their second appointments this week or next, they probably won't get their second dose. So how do we combat that? I mean, we've already got a system that is hurting in this distribution process, and now we have our citizens going to other places and trying to get doses that weren't necessarily accounted for them. So that puts now another county or another state in a bind. How do we fix that? Is it fixable? I mean, obviously the state governments are the ones responsible, but at the end of the day, we are a country together. And so, if Florida is hurting and you have the resources to go to Virginia or whatever, that now puts those citizens in a bad situation. So what are we going to do? Is there conversations about that, or are we kind of flying by the seat of our pants, so to speak, to deal with that?
So I'm not flying by the seat of my pants, but I'm also a Black woman in Washington, so I don't know who's going to listen to me when I say certain things. I've been talking about interstate travel as well as the impacts we saw last year of things that we could predict impacting a thing that we could not predict. By that, I'm talking about natural disasters. When I was working on Zika policy on the Hill a few years ago, I was working with Congresswoman Stacey Plaskett of the U.S. Virgin Islands, and a lot of people don't understand the dynamics of trying to receive quality health care for people of color in the U.S. territories, especially Black people. So folks don't understand that as a baseline. And then they also don't understand how, hurricane season, which is unavoidable, right? And comes every year like clockwork, really impacts the delivery of quality healthcare services to those populations. So last summer, I was trying to, talk to some of my colleagues and say, hey, a lot of natural disasters might be coming around, given that it's hurricane season. We might have flooding, we might have forest fires in California. What should we do? And people looked at me like I had a third eye. They're like, what? What are you talking about? COVID-19 is so bad. Like, we don't have time to think about hurricanes. And then a whole bunch of people in California lost their homes. People were, digging their belongings out across the South and the Midwest because of flooding. And not a lot of folks paid attention to that news because it wasn't really as flashy as COVID-19 issues. But I will say that the problem there, once again, lies with state dynamics. The best thing we have is trying, as at least members of Congress on our side, and also hoping that the new administration will build really strong relationships with folks on the ground, not only state government stakeholders, but also folks in private industry and community health leaders, folks who run community health centers, and really try their best to improve the systems that we already have, including scheduling. Vaccine storage and management has been a big issue that I've been trying to raise since last fall. It's not as sexy as other issues, but when you're talking about vaccine allocation or distribution, you can't assume that a community that does not have the capacity to store, Pfizer or Moderna vials because they don't have the appropriate, ultra cold freezers that are extremely expensive because you never provided funding for that. You can't expect those folks to be able to deliver those vaccines to their underserved communities. Meanwhile, in major cities, someone unplugged the freezer and like all these doses, went to waste, or, very strange kind of administrative things are happening such that, vials are being wasted or tampered with, et cetera. Meanwhile, folks in underserved communities still don't have access. So there are these contours that are really sticky, especially interstate travel, and also certain travel within metropolitan areas in certain counties where folks who have the financial means to travel will do so. and take those resources from folks who really don't have the means to travel somewhere else to get them, in a race to like get the vaccine, which is not only something that's difficult because it's not necessarily illegal and we can't legislate against it, but there are ways in which states and local jurisdictions can, impose policies that actually, make sure that doesn't happen, or smaller kind of measures to prevent folks from abusing systems like that. But it starts with really highlighting the issue. That will start coming in the coming months with letters from members of Congress to the administration, as well as different rollouts coming from the Biden administration in terms of executive orders and how they plan to expand, HHS to really handle those issues. But it is tough because you can't necessarily arrest people for abusing the system. Also, there's this very strange concept that the vaccine is like makes you impervious. Like, so people think they're racing to get something that makes them invincible and allows them to go out and act like the pandemic isn't real, which is not necessarily true about the vaccine. So it's a tough spot.
Thank you. Dr. Michener, did you want to comment?
Sure. I mean, there's a lot there, but I guess I would just add that these intergovernmental dynamics are especially crucial. I am a scholar of health policy, but a political scientist by training, and I wrote a whole book about Medicaid and federalism, right? And so even before this pandemic, dynamics around federalism and intergovernmental relationships, and not just between the federal government and the states, which is one level, but also between the states and sub-state units like counties and cities, et cetera. Those levels, even prior to the pandemic, were sources of inequality, right? Because some states have more resources than others, some cities, some counties, et cetera. And there's a certain degree to which it's a sort of pattern in the US context that the form of federalism that characterizes our political system is a very liberal, and I don't mean in an ideological sense, but in a sense that states and localities have a tremendous amount of discretion in this country, and they really make a wide range of decisions with respect to health policy and with respect to public health. And that is an aspect of our larger political structure that we've really been pushed to contend with in the context of COVID-19. And what I would point out is that it has real implications for inequality, right? That what in a sort of arbitrary inequality, and most inequality is, but it means that where you live is going to, in many ways, arbitrarily decide what resources you have access to with respect to forfending against this pandemic. And of course, where you live, whether it's what state you live in, what county you live in, what city you live in, what neighborhood, down to what neighborhood you live in, is connected to a range of other axes of inequalities. We have segregation. That means that Black folks tend to not live where white folks live. And then we have all manner of division, urban, rural, et cetera. So, I'm here at Cornell, a faculty member at Cornell in upstate New York, and we have people who are thinking there are more vaccines available upstate, right? So they're coming from more heavily populated urban areas, hoping that they can come to upstate and get vaccine here, right? That has implications for less urban areas as far as what residents here are going to have access to. And certainly there are policies or practices that localities can engage in to try to prevent that kind of cross-locale travel in order to try to get access. But ultimately, it's not the people who are trying to get that access that are the problem. It's the system that hasn't sufficiently coordinated, right? So I think that regional coordination, cross-state coordination, and ultimately federal state coordination is quite crucial, right? And that certainly happened in the initial wake of the pandemic in places like New York, where we saw like New York, Connecticut, Pennsylvania, New Jersey working together, recognizing that their borders are porous and their populations are overlapping. I might work in New York and live in New Jersey, et cetera, and working together to try to come up with kind of regional plans for some of the different aspects of the virus. And I think that's the same sort of thing that we need to see happening with respect to vaccination. But, you know, if we weren't good at that kind of thing prior to the pandemic, it's not magically going to be something that we're able to navigate during the pandemic. That's like building a plane as you fly it, and it doesn't bode well. So what I do hope happens is that all the mistakes that we're learning, that we're making now, feed into a future process where we develop structures for dealing with these kinds of dilemmas, so that, you know, when we hit our next cycle of pandemic, or even as we continue to navigate this one over the next year or more, that we can grow and learn along the way about how to do things better.
Thank you. Dr. Atoyemi, did you want to add to that? I saw you shaking your head as we were kind of going through.
I'm in agreement with Dr. Michener, and in terms of at least the on-the-ground healthcare, I work as a hospitalist in an outpatient clinic, and the distribution right now just seems like every man for himself. And it's just a human survival method. If I had the means and I wanted to get my grandma to this other place because we aren't getting in my community, I'm going to do that. So again, to not put that villainous role on the people who are doing that, but back on the distribution plan, that it's so, again, it's just, to me, it's like a Hunger Games, every man for himself, get what you can. And if we could organize the distribution, I mean, even recently now, they're announcing that dentists and more other providers can administer the vaccine. But again, my concern is who's tracking these? Who is monitoring all these vaccines that are being given, in terms of, even now with vaccinations, even in my office, if someone has moved, I live in Georgia and work in Georgia. If I have a new patient who's coming from Chicago, New York, other places, I can't even see what vaccines they've gotten for their like well child checks. Their system right now does not cross over. So we can't even track vaccinations. So as Dr. Michener was saying, the lack of structure in our current system for vaccine distribution and planning is already lagging the needs that we're having, again, just in even doing routine well child vaccinations. When children are coming from out of state, I have no idea what they've gotten unless the family brings the vaccine records. So again, we need to improve and look at ways we can use our current technology and resources to make this system more efficient. And now, as people are getting vaccines in the pharmacies, urgent cares, all sorts of different locales, we're losing, well, I'm concerned we're going to lose track of where things are going to be given. And patients may be getting the first dose of this urgent care, and then they scramble to their community health department for the second dose. And we don't have the manpower capacity to track it. So again, going back, I also have my master's in public health, and just going back to the basics of the need to invest more money into public health. Public health is all about prevention. And sadly, public health is often underserved and it's underrepresented in healthcare policy. And public health has been screaming for decades about needing to have more in terms of tracing, contact for just every other infection, more towards education, more towards prevention. And we're all about doing the expensive, sexy treatments, and we have all these expensive, fancy things that we're doing. But public health is the bedrock of healthcare, and we're not putting enough money and funding into public health. I mean, a physician working for the health department makes a fraction of what you make in private practice or with a healthcare hospital system. So public health right now is just not getting the needed attention. We need to put more funding into public health infrastructure, and that can help with vaccine tracking and improving vaccine distribution. And even if we had a stronger public health system, we could rely more on the public health departments to distribute the vaccines. But because public health departments have been understaffed, underfunded forever, probably. They have the training and they have had the means for doing this, but they just don't have the manpower and the resource to do it. So we're not even using the current systems that are in place to do this. And now we're just we have local grocery stores are doing it. Grocery stores are not equipped to be giving vaccines like this. And other places where people are getting vaccines, these are not places that have been traditionally used, and we have these other realms that have been used and have the training, and you have people with that, they just don't have enough. And if we can start to let go, I mean, so a lot of it goes back to capitalism, and again, that's more the public policy of chasing the dollar. And I work in a rural a rural community, and thankfully our hospital was acquired a couple of years ago by a larger healthcare system, because if we were still an independent small town hospital, I don't think we would have access to the vaccine, because we're pulling on our big brother flagship hospital in Atlanta who's coordinating this. But in my small town, my hospital is a 70-bed community hospital. I don't think we would be able to get access to the volume that we've gotten without our flagship. So again, that goes back to the disparities in access based off of the other speakers were sharing, based off zip code, based off of income, based off of even having the manpower who are going to coordinate getting this out. So it's not just even with the racial disparities, but the income inequality and rural versus urban versus suburban. So again, this response is highlighting those disparities. And to me, again, a lot of the solution lies in putting more attention towards our public health current system and strengthening that system that is already in our communities. You have health departments in predominantly urban and rural areas. We already have these places set up. We need to put more money, and that goes back to the politics of census and how many people are accounted for each community and how much money is going toward these communities and these current established places, to strengthen what's there and not trying to build something new for handling these type of crises.
Thank you. So thinking about what we can do, right? Yes, we are talking about the future of health policy, but as we know, sometimes policy moves very slowly. And so in this, as Dr. Atoyebi said, it does seem like the Hunger Games. And we can continue to wait for that policy, but in that waiting, how do we kind of move the needle towards funding for our public health departments? I also have an MPH, and we've been talking about prevention being the future of medicine forever, right? When it comes to cardiovascular disease, diabetes, but even in those diseases, things aren't really moving as fast as they should, right? I think all of us kind of expected that we would be here talking about these inequities way back in March, when it seemed as though our communities were not yet hit. But we knew that this was coming. So what do we do now? We are trying to build a plane as we're flying, and it's not working out too well, but that doesn't mean we can't be doing something. So what is that something we can do? And whoever wants to start, you can start.
I'm happy to chime in quickly, and then I want to make sure to leave space. But I will just say that a few different things. One, and I think this has come up, and it's important to underscore, to emphasize, which is that a lot of these decisions are determined in the realm of the political, right? And that's not just at the national level, where it can feel like we have a limited ability to really have an impact. But locally, I think there's a lot more bandwidth for making a difference. This is especially true if you live someplace that's not super heavily populated. In my county in upstate New York, I have pretty ready access to my local political officials, to my local public health leaders, and not just because I'm a professor at Cornell, but as a member of the community, right? And so I think that we can be moving in local spaces to really put pressure so that the resources that are available at that level, which of course are limited and they're not bottomless, but there are resources available at that level. There are decisions being made about the distribution and patterning of the distribution of those resources. And we can actually, just as denizens, as citizens, as members of the polity, we really can influence local elected and non-elected bureaucratic officials that are making these kinds of decisions. And so I wouldn't underestimate our power as ordinary people. And then the second thing I'd quickly say, you know, I'm not a physician. I'm not a healthcare provider. I am a scholar and someone who studies health policy and the healthcare system. But one of the things that I spend a lot of time studying are programs like Medicaid, for example, that serve relatively marginalized populations. And one of the things I think about is how those kinds of programs not only affect health outcomes, but also affect political outcomes, people's political lives, by sending them important lessons and messages about who they are, about whether their voice matters, about how and whether the government is willing to invest in them, and about how and whether they can engage in the realm of the political. And one of the things that I find in the course of doing this research is that physicians play an important role in empowering their patients, right? And that doesn't mean, you know, you talk to your patient about who to vote for, right? There are boundaries there, and those boundaries are worthwhile. But even something as simple as advocating for your patients with local and state elected officials, it's incredible to see how local elected officials respond specifically to politically engaged and mobilized physicians, but also treating folks like Medicaid beneficiaries and those that have the most at stake in some of these larger conversations around who is going to have access to medical resources, treating those people with dignity, pointing them to resources and to institutions that can empower and provide them with knowledge and voice. That's also something that many people who are physicians or providers can do in their day-to-day, daily practice. So that's something to keep in mind as well.
I want to piggyback on that. Again, I appreciate what Dr. Michener was sharing in the role as healthcare providers, as physicians. And I definitely would encourage you all to consider, again, the pay is sometimes a little different and the communities are not as sparkly and sexy, but the smaller communities, the rural communities are struggling. And we need more underrepresented minority providers in our communities of these smaller towns. In my community, I can count on one hand how many people look like me who are in primary care. So although I don't know if I'm going to be here long term, right now, the impact of my face being in that community and also taking on roles of leadership in my healthcare community are making a difference. I hope and I believe. And again, as my role, using my role to be an advocate for patients and for more equitable healthcare, and looking at some of the disparities, and I see different things, and many times I do have to do extra things of calling specialists and advocating. And as she was sharing, Dr. Michener was sharing about treating patients with dignity, but also teaching them how to advocate for themselves. And a lot of times, often, especially with the Medicaid population, specialists sadly they cap how many Medicaid patients they see. They see a certain number, and once they hit that number, they don't see any more, or the care that these patients receive is frankly inferior compared to if you come with primary commercial insurance. So I do encourage you all as future physicians of America and healthcare providers to consider, again, working in these underserved communities. And also, if you don't choose to do that, please consider working in a place that at least accepts these patients. And that was something I was considerate of when I was interviewing and looking for jobs as an attending, is what is your demographics? What is your breakdown of insurances? Yes, healthcare systems do want to treat people who are having commercial insurance, because Medicaid, Medicare reimbursement versus some commercial insurance, there's a difference. But I still was cognizant of finding out what their payer population was like. And then also asking, what is the community like in terms of, can my patients see specialists? And as a primary care doctor in a small town, I end up doing a lot because I don't have all those specialists who are there who are going to treat patients with Medicaid, or we have a local free clinic, and it is sometimes challenging to get the adequate care. So being mindful, and again, talking, if you are in a places in the future, if you're in a specialty clinic or you become a partner at a clinic, in a practice, of advocating for these patient populations and using your voice and your position to advocate for, we need to see Medicaid patients, or we need to up the volume of Medicaid patients we see, or what are other barriers that you're seeing from the hospital leadership or the hospital infrastructure that are preventing these patients from getting adequate care. And even, for example, with my hospital system, we were noticing that many of the patients in our community weren't getting mammograms. It turned out it was something as simple as our mammogram center was open Monday through Friday, 9 to 5. Well, most working class people are at work at that time. So we can remove a barrier by advocating, requesting weekend hours, after hours for mammograms. So these are tangible things that, yes, I know a lot of it goes with health policy and writing to our local leaders and advocating and getting involved with local governments, but also using your position. And in our communities, healthcare providers and physicians are looked up to, and don't take that for granted. So use your position and your voice and the clout that you carry as a physician or a healthcare provider to do more. And again, to be an advocate by empowering your patients, as we've been saying, teaching them how to advocate for themselves, teaching them how to talk with specialists, talk with these people, and find the places to get their care, but then also, again, considering leadership in healthcare, because again, that too is a way to make systemic changes, especially once you get into healthcare systems. And a lot of hospitals and private practices are being acquired by systems. And we have to have that representation in these hospital and healthcare systems to have folks who are saying, okay, yes, we are. The healthcare system is a business and we're looking at the bottom line, but this is not just about the money that's going in and out, but the less people who are going to the ER, that's less money that's being expended on healthcare. So we build a better infrastructure for primary care, for specialty care. So these patients are going to the ER for all these little things. If we have resources for our community members, we have to think in different ways to get the people higher up to listen to us. But yes, frankly, it does come down to a lot of dollars and cents, but there are other ways to promote. This is why you need to invest in these populations, because in the long run, once we are preventing this, then you won't have the burden on communities of less people working, or people going to the ER for primary care, or all these other things that are happening. So again, in summary, I just am encouraging you all to use your position and your voice as future healthcare providers and physicians for more than just self-gains of, yes, you're making six figures. Yes, you've been working towards this for years and decades, depending on your specialty, but don't lose sight of the other people and the other reasons.
I want to take a moment to talk there about investing in Medicare and Medicaid, investing in those communities. So one of the things we've known for a while is that there was a physician shortage, and COVID-19 amplified that a lot. And one of the things we've seen is, in response, a lot of new medical schools popping up, right? But people really don't know that there is a gate at the end of medical school called residency, and we don't have enough spots. So even with, I know there's some funding coming for residency spots, but it's still not enough. So how do you encourage students who've been thinking about medical school forever? They now see that the system really isn't designed to support physicians all the time. How do you encourage them to keep going, especially from our community, right? Because it's already a big undertaking to ask them to take on multi six-figure debt, and then you get to the end, and we know that there are disparities and equities in the residency process, and so they've done all this work, they have all this debt and know where to go. And some people don't think the risk is worth that take. So what do you say to those students?
I wanted to add really quick. I wanted to respond to the previous question and also your current question.
Yes, please.
So just to go back really quick, in order for medical students to be able to effectively advocate for themselves, they really need to be able to understand the landscape. And often it's not as easy to understand, how Congress works, how your state legislature works. But it is important when understanding why preventative health or public health kind of larger programs or programmatic funding isn't as popular. The Congressional Budget Office, there are some barriers when it comes to getting a CBO score for how much a public health related bill to especially prevent or significantly reduce the prevalence of a long-term kind of chronic condition like diabetes, et cetera. There are limitations because the CBO score will be impacted by this determination across 5 years, 10 years. If the CBO determines that something like that will cost the government too much in the next decade, it really isn't looked upon favorably by other members who may, on either side of the aisle, want to save money. So if the CBO score is not looking good, they're likely not going to co-sponsor the bill or push the legislation through committee out of concerns that it just won't hold up on the floor for a vote, and it's not worth putting something there that really won't hold up. On the programmatic side, from an HHS or another larger department, there's also the larger problem of the fact that many community-based organizations, community health centers, and a lot of other kind of health clinics that have great ties to underserved communities and also have the community trust and the reach to really change people's lives and keep them empowered in their health journey across their life. They often don't have the funding or capacity or political ties to secure really strong grant writers or have connections with state officials that could increase their chances of being considered for funding. So when that funding is provided through competitive grants through HHS, from the HHS secretary, you often find the same couple of organizations in each state always compete for those grants, and they always get them, and that often, especially with programs on the HHS side that are intended to address these structural inequalities, that dynamic of those health centers, et cetera, in those communities being under-resourced themselves puts them at a disadvantage when they try to get grant funding. So even if Congress was perfect and provided like billions of dollars for diabetes prevention, by the time that money gets through the states and local communities, it might not necessarily reach the places it was intended to reach. Beyond that, there are also very few people of color working in Congress. So vying for that funding on the appropriations level, we just had a great staffer from Approps go to the White House who's really well respected, really excellent. But she was like our star. There are very few Black and brown women, especially Black women, in health policy on the Hill. So it's really difficult to underscore and highlight those greater inequities issues when no one in the room even has seen them in real life or understands those contours or lives that experience. Beyond that, we do have a problem with like folks moving on to the sexy health topic of the day. So once this pandemic ends, the issue is, will we create this kind of temporary infrastructure with mobile clinics and different temporary resources for these underserved communities to solve the problem as it is now. But then when the pandemic is over, which really technically is whenever the government decides to end the public health emergency, which might not necessarily coincide with the actual end of the pandemic, those resources can be completely pulled away. And like all those communities will just have a rug pulled under them. Those resources they depend on for not only COVID-19 prevention, but also some forms of primary care will suddenly be gone because the issue is over and it's been solved. And folks in DC often don't think long-term, they just move on to the next. So that brings me back to the issue that you just mentioned with this question, which is residency and the issue of slots. Of course, House Ways and Means Committee that works with us, who's super great, they provide that funding that is untouchable because the lobbyists make it untouchable for residency slots through Medicare. And they've highlighted this issue too. One, that there are only so many slots, so it just completely becomes a stopper for anyone trying to enter the field of medicine. One, and number two, something that we've raised on committee, by we meaning probably me, which is that there is no federal support for a national pipeline or a federal pipeline to increase diversity in medicine. And that's really hampered us in our efforts to actually, end this pandemic, because not enough Black and brown doctors are in positions of power in their state through healthcare systems, as was mentioned by our other panelists, and also in their communities to really determine where resources go or flag issues for state officials, governors, and be taken seriously when they flag issues. So all of those issues are things people are still talking about, and something that's a part of advocacy, unfortunately it takes a very long time, is a whole lot of making your federal officials accountable for what they do and say. There are already conversations about diversity in medicine, but I'm hearing the same old solutions that aren't really solutions. They don't really take to task systems that in undergrad and grad school really deter people of color from pursuing a career in the field of medicine and staying with it, especially financial barriers. So pushing people in that conversation and forcing folks through advocacy, through outreach, especially members of Congress and different committees that don't necessarily always work together smoothly, especially when issues cross different sectors. Providing that pressure as medical students and as resident physicians is really effective, because then folks really can understand in terms of numbers, how many people reach out to them, how important this issue is. Creating that pipeline, doing collaborations between the Department of Education and HHS, and putting that into legislation is really challenging. Just to put together COVID-19 packages last year and staying up for 5 months at late at night over and over again to do that with different committees. There are so many. There's like an endless permutation of interpersonal politics between staffers and members that people have to navigate. So often when an issue like diversity in medicine comes up and people have to work cross committee or bicamerally between the House and the Senate, folks just back off because it's too much heat to handle for something they think might not actually happen or be supported on the floor. So those are three kind of major issues to consider, and it's worth it to reach out to your member's office, whatever district you're going to school in or you live in, or reach out to me. I can give my information out after this event. So folks, if they have questions about like how does Congress work or how does funding work, the appropriations process, I can provide clarity.
Thank you. So I'm really actually enjoying this conversation a lot, and I happen to look at the clock and our time is almost up. And there's just so much here to discuss, right? And I think the blessing of coronavirus, COVID-19, and despite the fact that this was a botched attempt at really getting a handle on this for the last year, is that, you know, we are coming to the table and we are talking. And even as a student, I know there have been moments in this webinar where even I catch myself feeling a little defeated, because these are the same things we've been talking about for years. I got my MPH a few years ago. And, you know, it's like, wow, I remember sitting in my first year of my MPH and we had this exact same discussion about something else. And a lot of years later, we're having the exact same discussion about something else. And so it can be defeating, especially as I look at my first job as a resident here shortly. But I think talking to you ladies has really kind of given us some tangible things that we can do at the local level, and thinking about just things that we can do, the difference we make in our clinics, and how we can kind of use our voice even without having the money. Most of us have a negative value, but there are still things we can do to support our community. So I want us to end there. I want us to each give one thing. If you had a student coming to you and saying, like, I want to do something that will make a difference tomorrow, what would be the one thing you would tell them to do or work towards doing to make that difference? Whoever wants to start.
I'll chime in. I think I probably have a little bit of an unfair advantage because I have students, because I teach. That's part of the work, and this is the sort of thing they come to me all the time and say. And I think that I tell them first, you know, do the work that you can do where you are. Get to know where you are and who the players are as well as you possibly can. Right? If find an example of local change that you admire or that you think aligns with your values, with your sense of what needs to be done, and figure out how it happened. Who are the players? Who are the movers? Who are the shakers? And get yourself involved on that level. And often there are local organizations that are plugged into a lot of the advocacy work and a lot of the activism and the political work that happens at local levels. And of course, that travels. It often travels up to the state level, and so on and so forth. So often it starts with, you know, a local organization. Find some set of people who are doing work that's really important and figure out how you can contribute. And you can do that tomorrow, right? And longer term, I think there are different things to consider. But in the short term, you know, we don't have to wait until. I always tell my students, you don't have to wait until you're 30 or 40 or however old seems really old to them, which is frightening to me now to see what they think is really old. But you don't have to wait until then, until you feel like you're well established in your career to do anything in the world that's making a difference. You can do it now.
Should I go? Going off of that, I would actually say much of the same thing, and also add that your voice really does have power. I think along a student's journey, especially going from high school to undergrad to medical school residency, folks think that they need to be, you know, whatever they see on CNN or MSNBC, to be involved in politics or to be engaged in policy in some way, shape, or form. But you don't actually have to kind of present in that way or act that way in order to really leverage your voice and your experience. Given the way that the pandemic has impacted our existing national physician shortage, there's an excellent opportunity advocacy-wise for folks to really push for diversity in medicine and improvement in our kind of med school pipeline nationally that can really make an impact. Folks have seen recently that their vote does count and their vote does matter. We're now in a position where, you know, it will take time to see change, but luckily we have a new administration that's more amenable to actually solving the problem. And that does really matter. But it also matters, like was mentioned before, on the state and local level, for folks to really be engaged and really shore up their specific experiences as students, as providers, and emphasize, really impress upon people that, you know, you're the future of the field, in order to make sure the message really sticks. Often people are very obsessed, especially in politics, with hierarchy and what you can do and what you can provide and who you're with, quote unquote, with what organization you're with. And there are very powerful, you know, lobbies in Washington, D.C., especially healthcare. But it doesn't mean that your voice isn't valuable and can't make a difference. Feel free to also reach out to the staffers, like I said, in the offices of your members of Congress, et cetera, your senators. They're there to serve you. So I say that to say, they're there to connect you with experts. If you ask a specific question about a committee or who I can talk to, they are required to connect you with me or one of our counterparts on other committees to answer your question. And so don't think that your resources are limited to just what's around in your local community. Also, you know, continue really being that person to advocate for and empower patients. I know it's kind of tough to gain a sense of what that impact is on a community level, but people really do value a quality experience and a dignified, respectful experience from their physician. I think people don't see it until later in their careers. I have doctors in my family. Maybe I'll be a doctor one day myself. But people really do have a different sense of themselves and have a different understanding about the power they really have over their own life and their own health, given their relationship with a really great physician. So don't think that building those relationships person by person, family by family, patient by patient goes unnoticed. You're making a big change by being that advocate and being that, you know, supportive system to that patient. But that's all I have.
That's a perfect transition to my summary as well. But I recommend using the space you're already in, and whether that's your church, mosque, religious place of worship, or if you're on a team or your family members, of having these discussions, and even within my family and with friends and with church members, of having these discussions on how to speak up for yourself, or how to, in terms of, for example, just OB care. If you're not happy with your care and you feel like they're not listening, with the high rates of maternal morbidity and mortality and maternal care, especially in Georgia, of just educating people I know. So if there's a friend I know who's pregnant, I'll tell them, ask for this. Or if you're feeling something like this, do this. And teaching the people I know personally and that I interact with on a regular basis of what kind of things to ask their doctor, or if they're going in for a procedure, what kind of things that they should ask about in terms of pros and cons and pre-op questions. So again, using the current circle that you have, and you don't have to go, I mean, yes, please do more, but if that's not reasonable for you right now with schedule, and training is exhaustive mentally, physically process. So if right now you're like, I just don't have the means mentally, physically, spiritually, emotionally to do more in terms of reaching out to write letters or to start this organization or nonprofit that you have future goals with, use the people you're already in a community with. And that may be, again, when you go to the barbershop, when you have any discussion that people are joking about different things, say different little tidbits, or at the hair salon or wherever you're already in community with, use those opportunities, discussions come up, or as you know, people who are having different medical and healthcare experiences, to talk to them, to empower them, to even with education on some of the things that promoting these disparities, on diet, on lifestyle, on exercise. Miraculously, I've gotten my family the last 2 years to do a Thanksgiving jog, run, walk. And that's just something I was like, guys, we're not going to be statistics. So again, starting within your own nuclear relationships and building out from there and having discussions with the people you already are talking to, just again, adding on these other aspects of things we're seeing that are affecting our loved ones, our friends. So starting in your circle, and then they can also continue to educate people, and you will be their resource as well. So use, again, the education you're gaining and your experiences to help impact and better those immediately around you. And we hope for a ripple effect that will continue to make the difference.
I think those were all great starting points, right? I think at some point in my medical training thus far, I've heard each of those things. And sometimes as medical students, we think we are superhuman and we can do everything for everybody. But it's nice to be reminded that you can't underestimate the power you have building these relationships one person at a time or one family at a time. We have not quite made it in my family to a Thanksgiving walk, jog, run. But you know, we try to have one piece of cake instead of two. So small steps. But also be inspired by the local change you can see and use that to make your next move or to figure out how you will be the change wherever you are. Ladies, I appreciate you guys so much for joining us on a Wednesday night and sharing your expertise and giving our members and our friends something tangible that they can use moving forward as we all try to get a handle on this pandemic and protect our communities to the best of our ability. To all of our guests watching us, we are going to put up a QR code for you to give us feedback. We hope you enjoyed being with us here tonight. Please take the time to give us that feedback. And for all of my members, one of the things you've heard is be a leader. And it is now time for the next leaders of SNMA to be chosen. So I need you all to go to your email. We've sent you the application. Fill it out, submit it so that you can be the next leader of SNMA, because we all have to start somewhere and there's no better place to start than the SNMA. You guys have a great night. Again, ladies, thank you so much for joining us. And until next time, be safe, be well, wash your hands, wear your mask. Good night, guys.